Dear participants, my name is Gab McDonough, and I am the Educational Action Supporting Officer at ERN-EuroBloodNet, the European Reference Network for Rare Hematological Diseases. And it is my great pleasure to welcome you to ERN-EuroBloodNet Topic on Focus on Constitutional Thrombocytopenia, which is an accredited European online educational program targeting health professionals organized by the ERN-EuroBloodNet and in partnership with the CRPP, which is the French Reference Center for Inherited Platelet Disorders, and the Filière MHEMO, which is the French Constitutional Bleeding Disorders Network. Before we start, let me share some home rules. Please note that the session is being recorded and will be uploaded to the EBN e-learning environment. If you do not wish to appear, please turn your camera off and change your name on the platform. Also, please be kindly informed that your microphone is muted. If you have any questions about the presentation, please write them in the chat. They will be addressed during the Q&A session at the end of the webinar. Also, as mentioned earlier, this program is accredited. If you would like to receive 1 credit for the session, please fill out the survey at the end. So with that, please welcome. Today's webinar is on thrombocytopenia and thrombocytopathy with a focus on Hermansky-Pudlak syndrome. And the speaker is Professor Barbara Zieger. Professor Barbara Zieger is a distinguished pediatric hematologist based in Freiburg, Germany, known for extensive experience and impactful contributions to the field. She heads the pediatric hemosthesiology department at the University Hospital Freiburg. Her expertise has earned her numerous accolades within the medical community, including the prestigious Günther Lundbeck Excellent Award in 2015 for discovery of a novel dysfunctional platelet receptor variant linked to bleeding diathesis. So with that introduction, Professor, the floor is all yours. Thank you for joining today.
Thank you very much for this nice introduction, Gavin, and I would like to thank the organizers of this webinar for the invitation to give this talk. Dear Chairman, dear colleagues, these are my disclosures, and these are the learning objectives of this webinar regarding inherited thrombocytopenia and pathy, the composition of platelet light transmission aggregometry, LTH, and platelet flow cytometry, and next generation sequencing leads to the final diagnosis in many cases. So the second point is congenital thrombocytopenia can be also caused by gene E defect leading to rapid platelet clearance. And the third, regarding thrombocytopathy with the focus of Hermansky-Pudlak syndrome, is that I hope that I can show you that the phenotype of Hermansky-Pudlak syndrome can be very diverse. As you all know, the platelet activation and adhesion and aggregation and secretion, as we see on these 2 images, is very important for primary hemostasis. The interaction with interactin proteins such as von Willebrand factor and fibrinogen is very important for good primary hemostasis. The characterization of platelet function and the molecular genetic defect is very important for the understanding of the platelet disorder. Inherited platelet disorders are a heterogeneous group which comprises receptor defects, platelet cytoskeleton defects, signal transduction defects, transcription factor defects, congenital rapid platelet clearance, and storage pool disease. Regarding these subtypes, it depends on the gene defect if a platelet disorder is not only associated with thrombocytopathy, but also with thrombocytopenia. Therefore, it is elementary to identify the molecular genetic defect. And therefore, in the Children's Hospital in Freiburg, we established an NGS panel comprising 95 genes associated with thrombocytopenia or thrombocytopathy. Inherited thrombocytopenias can be caused by defective megakaryocyte maturation or by defective platelet production or increased clearance, and in some cases, the pathogenic mechanism is still unknown. Because of time limitation today, I could not show you cases of the at least known 41 cases with thrombocytopenia, different platelet disease with thrombocytopenia. So I can only show you 5 different cases. And especially I want to show a case with gene E defect, because meanwhile, since 2018, 2021, this pathogenic mechanism has been solved. So the agenda is first to show you cases with thrombocytopenia, and most of them also have thrombocytopathy. Then I will show the case about gene E-related congenital thrombocytopenia, and at the end I will talk about Hermansky-Pudlak syndrome. This 11-year-old boy suffered from mucocutaneous bleedings and increased postoperative bleedings after adenotomy and ureteroplastic surgery. His 14-year-old sister had also mucocutaneous bleedings. The parents had no bleeding symptoms. Laboratory analysis revealed thrombocytopenia, as we see here, and in the blood smear, as we see here, gray platelets. At that time, we still did in vivo bleeding time, and this was severely prolonged, as we can here see, over 15 minutes. Normal would be under 6 minutes, and flow cytometry showed reduced values of CD62 expression, hinting to an alpha granule secretion defect. Molecular genetic analysis revealed that he had a homozygous stop mutation in the NBL2 gene in exon 8, and this led to a stop code. And his sister had also the same mutation and the same phenotype. So NBL2 gene codes for neurobiogene-like 2 protein, which is essential for platelet alpha granule development, and it is inherited autosomal recessively. So this case was very straightforward. However, so this was gray platelet syndrome. However, I will show you with the next 3 cases that it is not so easy to solve or identify the diagnosis in patients with thrombocytopenia and thrombocytopathy using only the clinical phenotype and some of the biochemical phenotype. So these 3 cases all had thrombocytopenia, mild thrombocytopenia, and mild bleeding tendency. I will talk you through the 3 cases. So this first one is a familial thrombocytopenia. The mother and 3 daughters are affected. One of the daughters were the index patient. So the thrombocytopenia was between 68 and 136 G per liter. They were suffering from menorrhagia and hematomas. As we see here, the platelet counts of the affected family members, the MPV, which was slightly increased. We see that LTA did not help us so much with hinting the diagnosis. However, in flow cytometry, we saw reduced levels for CD62, which we can see here in grays, compared to the black column of the control, and decreased levels for CD63, which we can see here. So next generation sequencing revealed heterozygous pathogenic variant in ACTN1, and the disease is inherited autosomal dominantly. So this was a known pathogenic variant. The platelets are known to be slightly reduced, and MPV can be normal or slightly increased. Protein mapping shows that this amino acid is important for forming salt bridge. So ACTN1 gene encodes for alpha-actinin 1, which is expressed in megakaryocytes and platelets, and alpha-actinin 1 links actin filaments in bundles. So we see here the affected family members. The second case was a 2-year-old girl with mild thrombocytopenia, normal MPV. LTA showed impaired aggregation after stimulation with collagen, ADP, and epinephrine. Flow cytometry showed reduced levels for CD63 expression after stimulation with thrombin. Bone marrow biopsy did not show any signs of AML or MDS. NGS, using copy number variation analysis, identified heterozygous pathogenic RANKS1 gene deletion, which we see here in green compared to the normal controls. So we see here again the deletion because we confirmed this result using microarray analysis, and this confirmed the deletion. And RANKS1, you see it here, is one of these genes. All the others are not involved in thrombocytopenia or pathia. RANKS1 is a transcription factor important for regulating hematopoiesis and megakaryocyte differentiation. RANKS1 influences multiple genes involved in megakaryocyte differentiation. Patients with RANKS1 defect show an impaired megakaryopoiesis and therefore mild thrombocytopenia and platelet dysfunction. Germline RANKS1 defect is associated with RANKS1 familial platelet disorder with predisposition for myeloid malignancy. 25 to 50% of the individuals with RANKS1 FPDMM will develop AML or MDS, with a median onset age of 33 years. However, we also have seen one child who was about 3 years developing MDS and AML. In the third case, this was a 15-year-old girl with suspected normocellular MDS of the RCC refractory cytopenia of childhood type. The thrombocytopenia was first noticed at the age of 7 years when she had a respiratory infection. She had only mild bleeding tendency, no need for transfusion. She had a slight immune dysregulation, no vasculitis. She had repeated influenza infections, but otherwise no tendency to infections. She had scoliosis and she had atrium septum defect. Many investigations had been performed, but they were all negative before she came to our outpatient clinic. Due to the mild thrombocytopenia and the MPV, which was a little bit increased or borderline, she presented in our coagulation outpatient clinic at the age of 15 years, and we performed platelet flow cytometry and NGS. We see that there are reduced levels of 62 expression and more severe of CD63 expression. And when we performed CNV analysis, we saw heterozygous deletion of the Fly1 gene, and we confirmed this by microarray analysis. And we see here the decrease, the deletion in CNV analysis compared to the control in blue. So Fly1 gene encodes for friend leukemia integration 1 transcription factor. It regulates vascular and angiogenesis, as well as megakaryopoiesis. Genetic alterations of this gene are associated with Fly1-related thrombocytopenia, or in Omin called bleeding disorder platelet type 21. This is caused mostly by missense variants and causes a mild moderate macrothrombocytopenia and functional platelet defect, storage pool defect. And the genetic alterations are also associated with Jacobsen syndrome and Paris-Trousseau syndrome, caused by hemizygous terminal deletion of 11q of different sizes, including FL1 gene. So these patients have different phenotypes depending on the size of the chromosomal deletion. It can be facial dysmorphology, retardation, heart defect, immunological or hormonal problems, and dysmegakaryopoiesis, which leads to thrombocytopenia and the alpha and the delta granule secretion disorder, as we have seen in this patient. So to sum up these 3 cases, so the first was caused by ACTN1 related thrombocytopenia. The second was caused by a RANKS1 deletion, and the third by Fly1 deletion. So these 2 have been missed if we would have been missed if we would not have performed copy number analysis. And this patient needs further follow-up in the outpatient clinic of hematology oncology, and this not as she had been before in this follow-up. So I hope I could show you that it is very important to identify the diagnosis. Next, I will go in G&E-related congenital thrombocytopenia due to rapid platelet clearance. So the G&E defect is a sialylation defect. G&E is a bifunctional enzyme with an epimerase domain and a kinase domain. And I will talk in the next minutes only about the kinase domain. G&E is a key regulator of sialic acid production. It regulates biosynthesis of a precursor of sialic acids. This is called N-acetylneurominic acid. Sialic acids are terminal sugar components of glycoproteins and glycolipids on the platelet surface or on the surface of the cell. And we see here in platelets, they are up here. So in G&E is required for this normal sialylation on the surface in hematopoietic cells. If platelets lose these sialic acids during circulation, they are cleared via the hepatic Ashwell-Morel receptor. In the past, G&E defects had been classically associated with G&E myopathy, a rare slow progressive distal myopathy with an onset usually in adulthood. More than 180 pathogenic variants are currently known with great phenotype variability. In some of these patients, thrombocytopenia had been reported. Classically, there was another disease associated with a sialuria, an impairment of sialic acid metabolism, but this is a specific mutation and I do not want to go further in this. However, in 2018, NGS identified G&E variants in children suffering from severe moderate thrombocytopenia only, no myopathy. So this newborn girl had intracranial bleeding after birth and suffered from congenital severe thrombocytopenia. She needed weekly platelet transfusions. Before she came to our hospital, many diseases, as you can see here, had been excluded. When she came to our hospital with 6 months, she had a platelet count on that day of 90 G per liter. LTA showed impaired aggregation after stimulation with ADP, epinephrine, and collagen. Flow cytometry showed a decreased von Willebrand factor binding, which we see here in red, and also decreased values for CD62 and decreased values for CD63, hinting to an alpha granule and delta granule secretion defect. NGS revealed novel compound heterozygous G&E variants, which we see here in the NGS reads. We see here that the MAF was very low, and it had not been listed in the HGMD database at that time. And our programs, which we usually run through for new variants, they all said delirious, disease-causing, probably damaging, and the SCAT score was increased. So when we then performed in silico modeling, we saw that these wild-type amino acids normally are important to form hydrogen bonds with ADP, beta, and alpha phosphates, and that the pathogenic variants are disrupting this ADP binding. In addition, together with Karin Hofmeister, we performed lectin microarray, and this is to analyze the platelet glycoproteins to measure the alterations in sialic acid expression on these platelets. So lectins are proteins that specifically bind to certain carbohydrate sequences. And we see here that the patient platelets had decreased alpha-2,3 sialic acids, which we can see here. And then in return or reciprocally, they have increased terminal galactose binding lectins. And we can see this specifically here with Ricinus communis lectin. And this combination is hinting for a G&E defect. So the patient already had been treated with neuraminidase inhibitor and thrombopoietin receptor agonist, but she had not shown any response. Because of the severity of the disease, hematopoietic stem cells transplantation was performed and normalized platelet count and platelet function. And so far, this child developed completely normal and has no bleeding symptoms anymore and no myopathy so far. So the mutation was in this kinase domain, and meanwhile 7 publications have been published and showing that newborns or infants with this with thrombocytopenia had pathogenic variants in this area. And so the question is this a new hotspot for thrombocytopenia? Meanwhile, Omin calls this disease thrombocytopenia 12 with and without myopathy. So I come to my last part, the thrombocytopathy with focus on Hermansky-Pudlak syndrome. Hermansky-Pudlak syndrome is caused by defects in 11 genes and proteins involved in biogenesis of the following organelles. And these proteins are involved in protein transport. So if in Hermansky-Pudlak syndrome, there is a defect of the melanosomes, and this explains the albinism. There is a defect in dense delta granules of the platelets, and this explains the bleeding tendency. And in Hermansky-Pudlak 2 and Hermansky-Pudlak 10, there is also a defect in cytotoxic T cell granules, and this causes the immunodeficiency. This 11 Hermansky-Pudlak syndrome genes and proteins are involved in the biogenesis of 4 ubiquitously expressed multi-subunit complexes. They are called block 1, block 2, and block 3 and AP3, adapter protein 3 complexes. And because of the time limitation, I cannot show you patients of all these defects. We have seen many defects. I will only present one of each block. And I want to point out here that in block 2, if somebody suffers from block 2 defect, these are oft milder phenotypes and can be easily missed. And the AP3 defects are those with the immunodeficiency. So this 4-year-old girl with albinism and nystagmus, as we see in the movie, which does not work anymore. It worked a minute ago. So she has albinism and she has nystagmus. And she had sometimes mucocutaneous bleeding when brushing her teeth, but she had no severe bleeding tendency, no surgery. The laboratory analysis revealed that the in vivo bleeding time was prolonged 15 minutes. Platelet aggregometry was impaired, as we can see here, and CD63 was reduced, as we can see here. Molecular genetic analysis, at that time we still did Sanger sequencing, revealed that she had a compound heterozygous pathogenic variants, and her brother had the same mutations and the same phenotype. So this was clear. Hermansky-Pudlak syndrome type 1. This is a completely other story. This 2-year-old boy had oculocutaneous albinism, recurrent infections, hepatosplenomegaly, mild statomotoric retardation, mild facial dysplasia, and the X-rays of the hip showed dysplastic acetabular. Before, he had no bleeding symptoms, no surgery. However, after tooth extraction, he had severe bleeding symptoms, and that was the reason why we were called. Until then, laboratory analysis had shown that he had neutropenia, impaired maturation, impaired NK cytotoxicity, impaired CTL-mediated cytotoxicity, and reduced CTL degranulation. Krischelli syndrome had been suspected because they had identified a heterozygous mutation in RAP27A, and they were still looking for the second mutation. When we performed LTA, we saw an impaired platelet function after stimulation with ATP, as we can see here compared to the controls. In flow cytometry, we saw that CD63 is expressed right at the beginning, before stimulation, and could not be stimulated further on with thrombin. And this hints to lysosomal missorting, and is very typical, this picture image, for Hermansky-Pudlak syndrome type 2, as we found in meanwhile. So when we performed electron microscopy, we saw that there is a lack of dense granules, and if we found some, they were enlarged. Molecular genetic analysis revealed homozygous nonsense variant in exon 8 in AP3B1. So it's Hermansky-Pudlak syndrome 2 and led to stop codon. The parents are consanguineous and they are heterozygous for the mutation. The boy died because of hemophagocytic lymphohistiocytosis at the age of 3 years. This 60-year-old female came to us with oculocutaneous albinism and increased bleeding symptoms, GI bleeding. Her brother had the same symptoms, but the diagnosis had not been identified. The brother died because of bleeding symptoms. So when she came to our outpatient clinic, we could see the decreased levels for CD63. And here we also performed mepagrine uptake and release. So this is the control, but this is impaired in the patient. And we performed electron microscopy. And here we see the loss on lack of the dense granules compared to the normal control. So molecular genetic analysis revealed, using copy number variation analysis again, that there is a homozygous deletion of exon 6, as we can see here, in the gene DTNBP1, which is coding for the protein disbinding, and I come back to that in a minute. So then we performed cDNA sequencing of platelet-derived RNA, and we could show that exon 6 and 7 are not expressed. And then we could also show that the disbinding protein is not expressed in Western analysis anymore. And this was then the diagnosis, Hermansky-Pudlak syndrome type 7, which is very rare. The last case is a 6-year-old girl with hematoma and epistaxis and no oculocutaneous albinism. And when she came to my outpatient clinic, we could see that she had severely reduced platelet CD63 expression, as we can see here in red, and profoundly impaired mepagrine uptake, confirmed the severely impaired delta granule secretion. And in electron microscopy, we could see the lack of the platelet dense granules. We were puzzled at the beginning here and performed molecular genetic analysis, and were surprised to see that she had a compound heterozygous variance of unclear significance, as we can see here. And all the programs showed that they are maybe disease causing, and this showed also that this would altogether suit to Hermansky-Pudlak syndrome, syndrome 3, type 3, and this has a very mild phenotype. So because we could not see any ocular cutaneous albinism, we sent her to a very special ophthalmologist for ophthalmological examination, and he could identify a partial ocular albinism. So I summarize. I hope I could show you that the NGS analysis has significantly improved the diagnosis of inherited thrombocytopenia, and that as a differential diagnosis in congenital thrombocytopenia gene E defect leading to an increased platelet clearance should be considered. And regarding thrombocytopathy, that the phenotype of Hermansky-Pudlak syndrome can be very diverse and is not always associated with obvious oculocutaneous albinism. And at the end, I would like to thank my group, especially Dr. Doris Böckelmann, who is in this webinar, listening to this webinar, and she performed the molecular genetic analysis, and also the physicians and the technicians and the students who helped in this work, and also our former boss, Professor Charlotte Niemeyer. And I thank all our collaborators and the German Research Foundation for funding, and I thank you for your attention. Thank you very much.
Great. Thank you so much, Professor, for your clear and very interesting presentation. That's wonderful. As mentioned earlier, I just wanted to mention that now we can do the Q&A session. If you do happen to have questions, you can enter them directly into the chat, and I will read them out loud for the professor so that she can answer them. And that was a wonderful opportunity. Just to make a quick announcement, as mentioned earlier, this is part of a 15 webinar series, and I just wanted to make an announcement for the next webinar, which is on December 18th. I will put that in the chat. I'd like to say that this webinar series wouldn't be possible if not for the 3 experts that have helped coordinate this webinar series, and would not be possible if not for experts like Professor Zieger, who's willing to share her time and expertise. So thank you so much. We have one of the questions from one of the coordinators, Mathieu Fiore. Do your patients with HPS have experienced severe bleeding symptoms?
It depends. So in Hermansky-Pudlak syndrome 1 and 4, yes. They had severe bleedings when they developed colitis when they were about 17. Otherwise, doing daily routine, not. Maybe they have epistaxis or hematomas, but if they have surgery in mucocutaneous areas, I'm very careful. They can develop also severe bleeding symptoms, as the patient did also with Hermansky-Pudlak syndrome type 2, who really developed very severe bleedings after they had extracted several teeth. And so they called me in the OR to stop the bleeding, which we could finally. So it depends really on the patient and the situation. And then I mentioned the patient with Hermansky-Pudlak syndrome 7, and her brother, he had meanwhile developed hepatitis B and experienced very severe bleedings. And finally, he also died because of these bleeding symptoms, because the diagnosis had not been identified. So I do not know what the therapy was there, but maybe we could have saved the patient if we would have known the diagnosis. And I also, I did not mention it. I also identified the diagnosis in a 7-year, then when she came to us in a 7-year-old child, and before she was about 4 to 5 years old, when she had adenotomy, and that was abroad, and they had not identified the diagnosis. And although the mother always said that she would have bleeding symptoms like epistaxis and hematoma, but they did not really look for the diagnosis, and they did surgery. The surgery went okay, but about 3 days later, she developed severe bleeding, life-threatening bleeding. She needed reanimation, and after that, she was retarded. And then the child was sent to Germany, and we identified the diagnosis. So this was also a very severe bleeding post-surgery.
Great. And we have a follow-up question from our same coordinator. Do you use desmopressin to prevent bleedings in these HPS patients?
Yes, we do. So first we use tranexamic acid, then we use DDAVP, but it does not always, it helps, but maybe it helps not sufficient. And since I'm a pediatrician, we don't use it if the child is not at least 3 years old. And the next thing which we would use would either be activated factor 7 or platelets.
Great. Thank you so much for the question, and thank you for the response. Once again, this is an excellent opportunity to ask questions directly to our guest speaker today with a wealth of knowledge. If you'd like to ask a question, you can do so and enter it in the chat. We have a follow-up comment. Thank you very much for your talk.
Thank you very much for listening and the opportunity. Thank you.
Mhm. Perhaps I'll ask one more. Oh, great. A question to the organizers. Are the previous webinars in the series available online somewhere? Can you provide a link? Perhaps I can answer that question on behalf of ERN-EuroBloodNet. We are in the process of editing and uploading all of those videos. We can provide an update on that shortly, but I would imagine that they will be done in the next 2 weeks or so. So I can put a link into the chat for our YouTube channel, but you can also find that directly on the EuroBloodNet website. So the major advantage of this website, or excuse me, this webinar series is that all of these videos are recorded and they will be eventually available on our YouTube channel for everyone to watch and rewatch. So I hope that helps. Are there any additional questions? Great, thank you. We're happy to do that. We have another comment. Thank you very much for your presentation. Perhaps I will ask one last time, if there's anyone with a question, please enter it into the chat. I just want to take a moment and say a special thank you to our 3 coordinators, Professor Marie-Christine Alessi, who's here present today, Dr. Paul Saultier from Assistance Publique-Hôpitaux de Marseille, and Dr. Mathieu Fiore as well from CHU Bordeaux. This has been a real pleasure to do this webinar series with these coordinators because they've been so proactive and it's led to this great success. So perhaps if there are no more questions, with that, I would like to thank you, Professor Zieger, once again for your clear presentation and for your time and your expertise. It's very generous and very wonderful of you. And with that, if there's no additional questions or comments, I wish everyone a wonderful evening. And thank you for your participation. So thank you once again.
Thank you very much for the opportunity to give this talk. Thank you.
Great. Thank you very, very much. Have a nice evening, everyone. Good night.
You too.